Hello and welcome. My name is Emily Messing, and I have shared a short summary of my professional background at the end of these slides. The title of my presentation is Disclosure to Patients and Families After Adverse Events. This is the relevant financial relationship disclosure for this presentation. These are the learning objectives that will be addressed during this presentation. These are the key abbreviations that will be used in this presentation. These are the key definitions used in this presentation. We're going to start by defining an adverse event as an undesirable occurrence associated with the use of a medical product in a patient directly associated with the care or services provided within the jurisdiction of a medical facility. Next, we will define a medical error as an incidence when there is an omission or a commission in planning or execution that leads or could lead to an unintended result. Of note, going through this presentation, there will be some legal terminology used, but please note that it's not expected that you memorize or define any of these legal terms. Rather, it's more important that you know that these terms are out there and can defer to your institution's legal team when needed. Let's start with a self-assessment question. Adequate preparation and showing true empathy are key to ensuring disclosure of unanticipated outcome events to patients or families is as successful as possible. Answer A is true. Answer B is false. We will return to the assessment question at the end of this presentation, where I will provide the answer and discuss the rationale. As you may have learned about in previous modules, To Err is Human, the pivotal report released by the Institute of Medicine in 1999 brought attention to the medical and medication errors occurring in hospitals within the United States. In that report, we learned that adverse events occur in up to 3.7% of all hospitalizations. Since that time, substantial effort has gone into improving patient safety, but we know that adverse events still happen. More recently, a study out of Johns Hopkins in 2016 actually estimated that medical errors were the third leading cause of death behind heart disease and cancer. Therefore, it's really important that institutions have a process in place to inform patients and their families when these events do occur, recognizing that disclosing a medical error to a patient is the right thing to do. But what is disclosure? Disclosure is defined as the communication between a healthcare professional and a patient, family member, or the patient's proxy that acknowledges the occurrence of an error, discusses what happened, and describes the link between the error and outcome in a manner that is meaningful and easy to understand by the patient. Of note, there may also be communication that's similar to this between patients and healthcare providers when we're unsure if an error occurred. But in these cases, it's helpful for patients and families to still receive similar communication with the caveat that we're still investigating what has happened. There are many reasons that it's important to disclose an adverse event to a patient, but most importantly, patients have a right to be informed about their care in order to make informed and educated decisions about their future care. Additionally, while it might seem counterintuitive, studies have actually shown that when a provider discloses a medication error or adverse event to a patient, it can actually repair the patient-provider relationship by increasing transparency about what is happening with the patient. Lastly, in addition to it being the right thing to do, there's also various levels of regulatory or accreditation, as well as institution-specific requirements as to when and what is required to be disclosed to patients. To further support all of the reasons that we just listed for disclosure to the patient being the right thing to do, the American Medical Association Code of Ethics also emphasizes the ethical responsibilities that providers have to disclose by stating that truthful and open communication between physician and patient is essential for trust in the relationship and for respect for autonomy. Withholding pertinent medical information from patients in the belief that disclosure is medically contraindicated creates a conflict between the physician's obligations to promote patient welfare and to respect patient autonomy. In addition to disclosure being the right thing to do, studies have shown that there are many benefits to a disclosure when it is done well. Not only does disclosing information about an event to the patient provide an opportunity for compassionate and patient-centered care, it may prevent further harm to the patient by allowing them the opportunity to obtain timely treatment or prevent the patient from worrying needlessly about the etiology of a new medical problem. Additionally, it allows for increased organizational learning from the event that ultimately could result in a safer system for patient and future patients. However, despite all of the known benefits to disclosure, there is still an evident disclosure performance gap, as we know that oftentimes harmful events are not discussed with the patients or their families. Even in the relatively rare instances when they are discussed, the disclosure event itself often falls short of what we would consider a good disclosure. Some of the barriers to why we either don't disclose or don't disclose well are listed here. Oftentimes, those involved in the error may feel shame or be fearful of blame or punishment by their institution and peers, or even be scared of litigation. Think about Redonda Vaught, the nurse who was fired from her institution and put on trial after accidentally administering a dose of vecuronium to a patient instead of Versed or midazolam. We hear often about stories, and this may reinforce our fears that we already have. There is also a concern that the patient will lose trust in their ability to care for them. Additionally, the individual may lack confidence in their communication skills if they have not been given the appropriate support or resources from their institution to help prepare themselves for such a difficult conversation. And lastly, a very common reason that disclosure may not reach the patient is that there might be unclear guidance from the institution as what it means to actually disclose and to whom. For example, practitioners have been cited stating that they felt like telling their risk management team about an event was them fulfilling their obligation to disclose an event, failing to realize that the communication might not find its way ultimately to the patient themselves. Now, I'm going to take a step back and focus on the fear of litigation, which is commonly cited as one of the top reasons that practitioners are afraid to disclose information about an event to a patient. The evidence actually supports that when a disclosure is done well, it may reduce the intention of a patient or the family to sue. Patients that do end up suing often cite the perception that the truth was withheld from them or that there wasn't satisfactory communication between them and their doctors. Given this information, it's really important that institutions have clear guidelines on when and what should be disclosed to the patient and make sure that their healthcare providers feel adequately prepared to have these conversations. Before we talk about the actual disclosure itself, let's talk about what happens leading up to that disclosure. What I've displayed on the screen is the general timeline of what may occur once an event is identified, which could be through a safety report or walkarounds, for example, that has ultimately reached the patient. Now we all know that this is often not a straight or linear line as this image may depict, but it's important for us to consider that the first steps to the left must occur before the disclosure can happen. If you're not a provider, you might be listening to the first part of this presentation, wondering what your role as the medication safety specialist is in the disclosure process, and let's begin to focus on that now. You, as the medication safety specialist, will likely be involved in the investigation into the event prior to the decision being made to disclose it to the patient or the patient's family members. Once an event or error is identified that has reached a patient, you want to first refer to your organization's policies on how to manage an event and escalate the report to one of the following groups, such as your risk management team within your organization, to determine if a disclosure is indicated. There are many factors that are taken into consideration when an organization is deciding whether a disclosure is indicated. Some of these factors include whether the event reached the patient, and if it did, how likely is it to cause harm or serious harm. Regardless of the factors that go into the decision to disclose, it's really important that all of the facts of the event are known before a disclosure is given to the patient or the patient's family member. And when I say all of the facts being known, I don't mean necessarily that the full investigation is complete. Instead, I mean that the whole healthcare team is in agreement with what happened and what the potential implications for the patient are. You can imagine that a disclosure is already a very stressful time for both the healthcare provider and the patient, and that would be made only more stressful if we didn't have all of the facts and had to keep going back to the patient with conflicting information. Lastly, the timing of the disclosure may influence the format of the disclosure. So up until this point, I think I've been kind of alluding to an in-person disclosure, which we'll get into some more details about further on in the presentation. But there are also other ways that disclosure can be given to patients, including a written disclosure. If any of you are familiar with the podcast, The Retrievals, in it, women recount how they received a letter in the mail stating that they may have received normal saline instead of fentanyl during their egg retrieval procedures. This is an example of when patients were no longer receiving care in the clinic, and therefore it was more appropriate for them to receive a written disclosure rather than calling them back into the clinic in order to receive an in-person disclosure. The decision has been made to disclose an event to a patient, but what does that look like? Typically, it's the attending physician caring for the patient who will disclose the error to the patient or the patient's family members. Oftentimes, this disclosure is done with a second person in attendance as the support witness. That second person may be a hospital administrator, risk manager, or quality assurance representative from the institution. While we want to minimize the extent that the disclosure is overwhelming to the patient, or I should say more overwhelming to the patient by having too many people in attendance, there have been studies that have shown that there are benefits to multidisciplinary disclosure, which can demonstrate the institution's dedication to caring for the patient and learning from this event. Regardless of who is present during the initial disclosure, it's important that there be one point person for the patient to reach back out to with any inevitable follow-up questions that they may have. Before we disclose an event to a patient, it's important to consider the patient's perspective in all of this. While studies have shown that their perceptions of and towards errors vary broadly, one consistent finding is that when an error occurs that causes harm, the majority of patients desire full disclosure and an apology. Specifically, they want it to be clearly stated that an error has occurred, how it's going to impact them, what led to it happening, how recurrences will be prevented in the future, as well as a genuine apology. When speaking about how recurrences will be prevented, it's important not to make the patient feel like we care more about future patients than we did for them, but more so about what we have learned and how we will improve as a system from this event. In summary, patients want truthful information delivered with emotional support and an apology with a clear follow-up plan. In order to be prepared and to be able to give this to our patients, healthcare providers need support and training to adequately prepare them for these situations. It's important to remember that the disclosure is a process and not a one-time event, and so is the preparation in order to give one. In order to deliver a successful disclosure, planning is key. Before speaking to the patient, the provider or providers planning on delivering the disclosure should agree on the goal of the interaction and logistical concerns such as where the location of the conversation will occur. It's important to remember that this will likely be an uncomfortable conversation, so the provider or providers should address their own internal conflicts before the conversation with the patients begin. In speaking with the patient, it's important to avoid blaming or pointing fingers at who may have, I have air quotes here, caused the error, and we want to stay away from using any sort of medical jargon that'll be difficult for the patient or patient's family to understand. We should make sure that we anticipate any questions that the patient will have and be prepared to answer those with all of the information that we have available at this time. Now that we've talked about what a good disclosure looks like and how we can best prepare for a disclosure, let's again come back to what the role of the medication safety specialist is in the disclosure process. So in order to help prepare all of your staff to disclose information about an event to a patient, you can help them be best prepared by advocating for your institution to have very clear guidance on disclosure. And so that includes when and what should be disclosed, who's doing the disclosure, what form the disclosure should appear in. In addition, you should advocate for training for the clinicians who are going to be involved in giving these disclosures. This training might involve simulations, attending classes, having available information to them, so that way when they are giving a disclosure, they are best prepared to deliver it in a confident manner to the patients. You should also be able to incorporate basic knowledge of the law and legal process when reviewing and investigating event reports. And again, like we talked about at the beginning, you don't have to have the legal process memorized, but it's important to be familiar enough with it when you are able to identify events that should be escalated up within your institution to a team that can determine if a disclosure is indicated. Lastly, you'll be able to participate in event investigations to help determine the potential impact of the error to the patient. And this possible impact to the patient might actually influence a decision and the format of the disclosure that will ultimately be given to the patient. Earlier in the presentation, I talked about how it's the attending physician who's oftentimes the one that's having the disclosure conversation with the patient. But I do want to spend the next few slides going over what actually goes into a disclosure and what that disclosure process might look like, so that you as the medication safety specialist are familiar enough with this process to, again, kind of help advocate for the training and the resources to be available for these providers who are doing the disclosure. So we're going to break it down and start with the initial conversation. In this first conversation, you want to review the facts of what happened, and remember, it's important not to speculate or touch on any information that you may not have at this point. While the patient might be asking for information, it's totally fine for you to acknowledge that we may not have all of the answers right now, but we will loop back with the patient and their family members as more information is available to them. We want to clearly outline the steps that are being taken to care for the patient in the moment as well as in the future. And we can also provide an information to them about where we are into the investigation and how we're going to work to prevent recurrence of this type of event from happening in the future. Towards the end of this conversation, you want to close out with sincere expressions of support, sympathy, and concern. And remember that many patients do desire to have an apology given to them that this event has happened. And it's really, really important that when we're apologizing to the patient, that statement does not end with a but. We want to give a sincere apology and give information on how we'll follow up with them. And we will then provide that information as more information is available to them. During the disclosure, we want to remember the effective communication principles that you've learned in school and throughout training. Some of these principles may include using open-ended questions, summarizing what you hear the patient say, or summarize the discussion that you just had with them. When doing that, you want to look for nonverbal hints as to whether the patient's understanding or looking like they may have more that they want to ask. It's important that we come into these conversations exuding empathy, making sure that it's clear to the patient that we care and that we have concern for their well-being, and that we are here and ready to address any of their questions that they may have. As part of the disclosure preparation process, you should also be prepared and anticipate what types of tough questions the patients may have. You should be able to provide and prepare answers for them with the information that is available. In addition to the questions that you are able to answer, it's important to recognize that there may be questions that you might not have all of the answers to, or questions that you're not going to be able to answer at any point, such as who is to blame for this happening to me or who is getting fired. Instead, you can ask open-ended questions to try to probe at the types of emotions or type of concern that's driving the patient to ask those specific types of questions. From there, again, you can kind of redirect them with the information that is known, or be able to provide them with a clear follow-up plan to get them the answers that we're able to provide with them once that information is available. As you start to wrap up the disclosure, remember that most patients do desire an apology, and this is something that I've said a few times now, so I'm hoping that this is a point that's been able to stick with you as you're thinking about disclosure. However, it's important to note that not all apologies are created equal. Patients desire a genuine apology that this is happening to them, and if we add a but statement to the end of that apology, it may result in the patient feeling like we're diminishing their feelings, or might leave them feeling like they didn't receive an apology at all. Next, after this, we're going to watch 2 short videos from AHRQ's Candor program that highlights both an inappropriate disclosure followed by an appropriate one. As you watch these videos, I want you to think about what points you will take away from both of these disclosures, whether that be things that you want to avoid or tips and tricks that you feel like were really successful and something that you might want to consider in your disclosure program at your institution.
Good morning, Mr. Thompson. I hear you had a rough night. How you feeling?
A lot better. I blacked out and woke up in the ICU. I had no idea I was so sick.
Well, let me tell you what happened. As you know, diabetes produces wide swings in your blood sugar levels. Last night, your blood sugar dropped down to 35.
35? It's never been that low before.
Yeah, that's dangerously low, and that's why you passed out. But we were able to get it back into your normal range, and you should be okay from here on out.
So why did my blood sugar drop so low?
I'm fairly positive it was a bad reaction to the insulin you got last night. We've adjusted the dose somewhat, and this shouldn't happen again.
Bad reaction. Is this insulin different than what I usually take?
Oh, no, it's the same stuff, but it looks like you got a little bit more insulin than usual. So now that we know how much you actually need, this isn't likely to happen again. I'm glad you're feeling better.
Wait. You know how much insulin I need. I've been taking 10 units for 4 years. Why would you change it? And exactly how much did I get?
Well, looks like the nurse gave you 100 units.
100 units? You can't be serious.
Look, I understand you're upset, Mr. Thompson, but there's no reason to yell. There was no permanent harm.
That's good. See you later.
You're in no condition to leave just yet. I mean, this is just a bump on the road. Things like this happen on occasion. I hear you had a rough night. How you feeling?
A lot better. I blacked out and woke up in the ICU. I had no idea I was so sick.
Well, you know, I'd like to talk to you a couple minutes about what happened last night, if you're up for it.
Uh-oh.
No, there's nothing to worry about. Though your trip to the ICU certainly wasn't part of the plan. But you're out of immediate danger now, and you seem to be back on track. Can you say a little bit about what you think happened last night?
Well, I really don't know much. I came in because I'm having trouble breathing, so you admitted me. Then last night, I started getting woozy and really sleepy. Next thing I know, I woke up in the ICU with lots of people around. Somebody said something about my blood sugar being real low, but they wouldn't tell me any more. Then they said it was safe to come back to my room. So here I am. But from the look on your face, I'm guessing there's more to the story.
You're right. What happened was that your blood sugar dropped down to 35.
What?
Which is why you passed out. But we corrected it quickly and there was no harm.
So what is it now?
Last check was 98 and you're stabilized. But what I want to talk to you about is why your blood sugar dropped so low. It was upsetting to us, and I'm sure you're not going to like it either. We made a mistake and gave you 100 units last night instead of your usual 10. I'm really sorry.
Wait. You gave me 10 times my normal insulin? Are you crazy? I could be dead.
I know. You have every right to feel angry. And we're committed to understanding what happened and preventing it from happening to anyone else.
Well, that's great for the next patient. But still, you could have killed me.
I want to be upfront with you so you have all the facts and answer any questions that you may have. What is most troubling to you right now?
Well, let's see. Maybe that I could be dead? And why in the hell didn't anybody in ICU tell me this?
We dropped the ball there. We wanted to make sure we understood what was happening before we said anything. We just didn't want to guess. But now I know we should have told you.
Okay. So what did happen?
Well, I wrote an order to give you 10 units of insulin. But the way I wrote it, it looked like 100. We have several safety checks to catch these errors like this, but in this case, it slipped through. I'm sorry.
I can't believe it. When my wife hears this.
We try to be careful to make sure all our patients get the right medications. But in case of diabetics, 100 units isn't all that unusual, so it didn't raise any red flags.
Still, the nurse should have known better, shouldn't she? Maybe she should go back to school. Try a different job, like waiting tables. Or is this your fault?
We all work as a team, and we all share responsibility when something goes wrong. I've worked with this nurse for many, many years, and she is an experienced, excellent professional, one that I would trust with care of my own family.
Yeah, unless they're diabetic.
I'll take personal responsibility for several things. I'll make sure you get all the information that you need. There will be an investigation, and we'll make sure we want to get your perspective over what happened. It's going to take a while to collect this information, but I'll keep you posted along the way. And just to let you know, I've already changed the way I write prescriptions. And I'll work with other members of your treatment team to improve the way we communicate. There are several other improvements we plan to make, and if you're interested, I'll be happy to tell you about those later. Does that sound like a reasonable plan, Mr. Thompson?
I guess. But I still can't believe this happened. And how am I supposed to trust your team not to screw up again?
You're right. We need your trust, and we let you down. But I promise you, we're committed to earning it back. We've reviewed all your medications to make sure they're correct. I hope you let us continue caring for you, but I understand if you'd want one of my colleagues to take over.
Well, let's see how it goes over the next few days. And what about the ICU? My insurance company's going to have a fit when they see this. Not to mention my boss. How am I supposed to make up for the time loss? I didn't have any personal days left.
These are important questions, and we certainly don't want you to suffer financially. Can I have one of our administrators come by later today to discuss this with you?
Sure. Look, I'm glad you told me about this, but I'm still pissed. You're supposed to be one of the best outfits around, and I still don't quite get how you could do this.
I hear your frustration, and maybe we should talk a little more when you've had a chance to think about it. I'll be more than happy to call your wife and talk to her about it as well.
Now that we've covered the initial disclosure and you've had the chance to watch 2 examples of disclosures being given to a patient, I want to now direct your attention to the follow-up conversations. Many organizations may do a reasonable job with the initial disclosure to the patient or the patient's family, but those same organizations oftentimes fall short on the follow-up conversations. So oftentimes, after a patient is initially alerted to an event happening, they might need to take some time to comprehend and process what has happened. And after a little bit of time, it's likely that the patient will have additional questions for the healthcare providers and the team that's taking care of them. Therefore, it's really important that after the initial conversation, we have a planned discussion on how we will be able to follow up with the patient and when these additional discussions will occur. In addition to answering many of the patient's questions during these follow-ups, we should be prepared to present the results of the event analysis and discuss what we've learned and what types of prevention plans have been put in place. Lastly, now that the patient has had some time to process what happened, they might be asking for compensation or what type of compensation they will receive following this event. And if that's the case, it's important that we have the right people in the room during these conversations. If you are interested in learning more about disclosure, here are some resources that are available to you. Oftentimes, your organization's own risk management team will have a number of resources that are specific to your state as well as your institution, and I would highly recommend reaching out to them as an initial starting point. In addition to them, many organizations' medical professional liability insurance companies will have resources that are available on their website or programs offered for you to attend. Lastly, AHRQ's Candor Toolkit can serve as an excellent resource and is intended to assist hospitals in implementing communication and optimal resolution programs. And so this would be a really great place if you're looking to either further develop or start your hospital or institution's disclosure process. Let's return to our self-assessment question that we started with at the beginning. Adequate preparation and showing true empathy are key to ensuring disclosure of unanticipated outcome events to patients or families is as successful as possible. And for those of you who have selected true, that is correct. I hope that now, by the end of this presentation, you are able to see why it is so important that there is adequate preparation that goes into the process for preparing the healthcare provider to disclose an event to a patient. That preparation should entail making sure that the healthcare provider knows all of the facts of the event of what has occurred, as well as has the appropriate communication skills and confidence going into this conversation that is likely going to be a difficult one with their patient and the patient's family members. In summary, disclosure is the right thing to do. Patients have the right to know about what has happened to them and what is going on with their care. There is no indication that a good disclosure leads to increased liability, and studies may actually suggest the opposite. Lastly, a meaningful and successful disclosure requires lots of planning and skills in order to successfully deliver a disclosure to a patient. These are the references used to develop this presentation. Thank you for your time and participation.